Okay, so Microtia, like I said, 3 situations I will, but before that, the basics of Microtia, because these are the ones which get applied into the, so Bhumkar ear line, some nonsense I have to keep doing, Aapki yatra sukhad raho. These are the 3 situations: post-perichondritis, cauliflower deformity, post-trauma, and in newborns. Specifically, this is what I will cover in today's talk. But Microtia, the basic principles, always, as an ENT, Microtia is always associated with atresia, and that as an ENT, we have to address that. And this is something which is important. Microtia comes in various forms, size, shapes, personalities. So we'll not get into this, but the goal is now from that deformity to make it into a beautiful looking ear in one single stage. All the subunits are created in one single stage. Only the post-oral groove is created in the second stage. So this is the destination and the path we will talk. Currently we are now, our surgery time has come to less than 3 hours because we've developed a wonderful team and coordination. So what does it involve? It involves the gold standard today is the rib cartilage framework. That is the replica of the opposite side. A template is made and a rib cartilage framework with all its subunits is made and put under the skin pocket, and then you apply vacuum which remains there for 3 to 5 days, and you get a near normal looking ear in every case that you have planned well. This is the framework which has gone. The deformed cartilage was removed, the subacute pocket was made, the skin, the framework was slipped under the skin, and a vacuum was applied. This is again some more. The variation here is the skin deformities tend to be different. So the skin incision is very variable. There is no one standard skin incision for this. So these are what we get when we apply the vacuum. This is 70 days. The skin starts to remodel itself very well. This is one incision now that we are playing with, going above, so we don't cut the skin which drapes the framework. What is involved? You have to take the 6th, 7th and the 8th costal cartilage, not the bone, the cartilage, and from that you make the entire framework. The selection criteria, the real scientific selection criteria is 60 centimeters of the chest circumference at the level of the xiphisternum. This gives you enough cartilage without causing any donor site morbidity or weakness. Typically in India, the age is about 8 to 10 years of age. That's the age criteria, but the real criteria for rib cartilage is 60 centimeters. And then you have a base plate, and then you have 4 subunits which you wire together to create a framework. On the left, you see the template made from the design of the normal ear. So these are some frameworks, and this is what, when it goes in, it drapes beautifully, and over a period of time, the skin remodels. Like I said, the skin incision tends to be different in different deformities, and this is where the learning curve is actually. These are some more. I'm just sharing more and more photos to inspire in you the feeling that ह्याचा video लागेल. So this is the deformed cartilage removed. And now the vacuum is applied, and this is the moment of excitement. And bingo, ear is born. On 2nd floor, Gokhale Road, Thane. Yeah. So you don't need anything fancy here. So one more, but forget it. This is what, over a period of time, the remodeling is better and better. I have now, as an otologist, my contribution to this space has been to add canal drilling in the same stage as we do either the first stage or now more and more the second stage. And I promise you that they get better sound localization. I do not create a meatus. I don't know how to show, but that red arrow you see, inside the canal is drilled, the ossicles are mobilized, all the atresia bone is removed, the ossicles become mobilized, and the patient, I don't know how, but the observation is they start hearing much better. It's a very unique experience for them, the sound localization. And multiple times we have done CT scans post-op. This is 4 years post-op. The bony canal never restenosis. All the atresia cases that have been failures are the soft tissue which keeps on trying to heal itself, and we've learned a new technique for that, but that is for some other topic. But this is what we do along with making the external ear. Now specifically today, post-perichondritis, after piercing or after an ear surgery, cauliflower deformities of different degrees, again, you cannot just do any soft tissue reconstruction here. You need a rib cartilage. External ear is about having a rock solid framework which is then applied, covered with a soft skin. You try to make anything soft, it is going to, the skin is very unforgiving and it will deform it. So you have to take the rib again, the 6, 7 and also sometimes the 8, but this is what is done. Again, this is done in 2 stages. The first stage is where you excise all the bad cartilage and you actually use the post-oral skin to cover the framework. This is another very bad case. This is actually a failed primary case, for which now, in this case, there's too much. There's no hardly any skin left. So you have to use a TP flap, the vascular flap that Prahlad was talking about, the superficial temporal artery flap, where at least 2 branches you should get. So we do a CT angio and plan our flap to get maximum vascularity in that, and then you apply it over the rib cartilage framework, and over a period of time, the ear and the skin starts looking nice. Now, not all trauma you can handle with doing surgeries. There are times when you have to resort to a prosthesis, and because if the superficial temporal artery is blocked, is damaged, one of course has an option of an occipital artery based flap, but these are little difficult to harvest, and getting them to reach and go anterior to the framework tends to be a bit of a challenge. So some people will undergo prosthesis. This is the quality of a prosthesis which is available abroad. Unfortunately, in India, we are trying to develop somebody to make a good prosthesis, but this is the best that we have come to. There's a dental surgeon in Dadar who has taken up this project, and we are supporting him. And it costing about 25,000 rupees right now to get this 1 year done. She's hemifacial microsomia, multiple other things. This is where currently. So it's not an option right now. The low hairline, this is just to show you the TP flaps. This is something new now. This is a synthetic material called Supor. There was a precursor to this which was Medpor, but this comes now as a ready-made thing with an absolutely normal looking external ear. The technique remains the same of using the TP flap, but the TP flap required for this sort of a framework of an ear is much longer and wider, but the results are excellent. This is one which we have done over a period of time. You see, it needs a very, very long 11 or 12 centimeters by 13 centimeters flap, and then over a period of time the ear starts to look nicer and nicer. This is not my picture, this is my friend's picture. She is in LA and she's the one who guides me in the Supor, what are the finer nuances. It looks wonderful. So this is something which, when I cannot use the rib, I am going to use Supor in all my patients. It comes in 25 different models, so we can pick up whichever is the nearest to the normal ear. This, I think, is very, very important. If you get to see a child, a newborn, within the first 2 or 3 weeks of the child with minor deformities, don't say with time this will get better. This is the time, the first 2 or 3 weeks, to start using molds. Now the challenge is how to fix the mold, but molds is what we need, and they can give magical results if they are started within 2 or 3 weeks of the birth, and we have to continue maybe up to 2 months or 3 months. So mold is something very important, and I'll just show you. Under the maternal hormonal influence, the cartilage is really, really very pliable and moldable. So one needs to do this. Placing the mold, again, depending on the deformity, you have to devise a way. There's no one way of fixing the mold, but it should be kept there. And the ear keeps increasing, the size keeps increasing every week. So you have to keep changing the mold as and when it starts to become loose. This was a very acute angle that the helix and the lobule had. We were lucky we could do this, and just in 2 weeks, it started to become straighter, and we got a very good result with this. Applying it was a big challenge. This is a very, very VIP patient from Delhi, but we managed to somehow convince the family that we can do it, and this worked out very well. This was another minor deformities of the helix. They can also be used the right mold. Sometimes you can use a wire underneath and keep the mold in place so that it has its memory. And in about a month's time, you can get a ear which otherwise the child would have needed to be operated upon in case this was to be. Now we have this Deepika Padukone. She has a minor deformity, a Stahl's deformity on the right ear. Had she seen somebody in 2 or 3 weeks of her, maybe she would have not had this. For sure, this year, this helix could have been definitely corrected had we seen her at 3 weeks of age. This helix is quite deformed, and this could have been just with simple mold made into a very good looking ear. But she's blessed with a beautiful face, so nobody except me has noticed her ears. So it's okay. Trauma, very easy. These cases tend to be very easy if the post-oral skin is nice and intact. This photo I have deliberately shown for effect or impact. This is after surgery, and this was his missing. There was a trauma to which, and then we had to use the rib and put the rib as the missing jigsaw piece, and then use the post-oral skin to simply cover it. This was the pre-op. When he came to us, this was the trauma. This again, you cannot use some soft tissue tunneling or something like that. You have to use a rib cartilage and make a good ear. This is the first stage, and in the second stage, you just lift the skin off. It's quite easy. Trauma cases are very easy. In trauma, if you try to just suture back the piece, it never takes. You need a microvascular anastomosis. If at all, many patients will come to you with that piece in hand and say, can you just suture it back? If you just suture the skin and cartilage to the remnant, it never works. It will always fail unless you are able to find a blood vessel and do a microvascular anastomosis, which is impossible. I have never done. Even in world literature, there are very few cases which have succeeded. This is another case. Playfully, the dog had eaten off a part. The jigsaw piece again fitted. He did not opt to. This much of the ear was missing, and this is what we created. So this is where the three conditions that I talked. This is where majority of my microtia work is. But we do see newborns, some infective cauliflower deformities, and trauma. Thank you very much.
Thank you, sir. Now I request our chairpersons to felicitate Dr. Bhumkar, sir. I request Dr. Ashim Desai, sir, to be on the dais for the next lecture. Topic is Allergy Unmasked, Hidden Culprit of ENT Diseases.